It is my pleasure to introduce the second speaker, Professor Dr. Kamal Ohasha, Professor of Internal Medicine and Nephrology, Tanta University, and the Vice President of Tanta University for Postgraduate Studies and Research. His talk will be about advances in treatment of hyperkalemia in CKD.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Professor Iman, for this kind of introduction. And I'd like just to thank Professor Salah Naga and Dr. Iman, Dr. Hussein Sheashaa, for inviting me to give this talk and this great meeting that we attend every year. Thank you so much again. And I take this opportunity to to give my sincere condolence again and again for Professor Amr Abid. May God bless him, and he's in the heaven, inshallah. And congratulations to Dr. Hala, Professor Hala, for taking the position of head of unit of nephrology, Alexandria University. Congratulations, and I wish you good luck, inshallah. As Dr. Iman mentioned, that my talk is going to be advances in treatment of hyperkalemia in chronic kidney disease patients, and in continuation to the electrolytes that have just Dr. Hussein and Dr. Hala just talked. I'm going to talk about one of the very critical electrolytes in the body, which is potassium. It's one of the dangerous electrolytes. If we don't care about it, as Dr. Hussein mentioned, it's going to be a myth for us as a nephrologist. So I'm just going to, if you allow me just for 2-3 minutes extra, it will be just very my honor, and you're very generous as usual. This is my agenda. Just briefly, some facts about potassium and hyperkalemia, like definition, clinical presentation, prevalence, and what risk factors for hyperkalemia, causes of hyperkalemia, and the challenges that you have in clinical practice for hyperkalemia in terms of RAS blockade and hyperkalemia. And I'm going just to talk briefly about the acute management of hyperkalemia, and my focus will be on chronic treatment of hyperkalemia. And in the theme of updates, I mean, on the newer medication that's not available in Egypt yet. I don't know when it's going to be available, but we have to mention it and know what is the scenario. And I will finish by summary of my talk. This is the definition of hyperkalemia. It's just vary according, but typically is defined as potassium more than 5 milliequivalent per liter, and hyperkalemia may be further subclassified into mild, moderate, or severe hyperkalemia, depending on the level of potassium, 5.5, 6, and 6.5 milliequivalent per liter. And this is a clinical presentation of hyperkalemia. Usually it may be presented with nothing, asymptomatic, but when presented, it may be presented with cardiac, some sort of dysrhythmias, muscle weakness, parathesias, nausea, diarrhea, and vomiting, and sometimes constipation. And the major and the critical manifestation is cardiac conduction abnormality, which just range from mild PR prolongation, QRS prolongation, to cardiac arrest and life-threatening arrhythmias. And severe hyperkalemia can be life-threatening if potassium is exceeding 6.5 milliequivalent per liter. And this is the prevalence of hyperkalemia. It may be present in general population. Up to 3% of general population suffer hyperkalemia, and in almost 1 to 10% of all hospitalized patients may be presented with hyperkalemia. Cardiac patient, up to 40% maybe suffer hyperkalemia, and chronic kidney disease, almost 50% of our patients may suffer hyperkalemia. So what about the risk factors of hyperkalemia? There are myriad of risk factors for all our patients. Simply chronic kidney disease, this is the first risk 1, and serum, just serum potassium more than 4.5. If the patient has this number, you should be very cautious when you prescribe medications that's well known to increase potassium, like non-steroidal anti-inflammatory, RAS blockade, and spironolactone, mineralocorticoid antagonist. Concomitant use of concomitant disease like heart hypertension, heart failure, diabetes, like RTA, use of medications that may influence the potassium excretion, for example, diuretics, RAS blockade, and mineralocorticoid, and increasing age. It may be related to some sort of catabolism or something. And dietary potassium intake, as Dr. Hussein and Dr. Hala were talking about. DASH diet. DASH diet is full of potassium, actually. These are the causes of hyperkalemia, and for the sake of the time, I'm going to just mention the heading. For example, increasing potassium load, altered potassium distribution, extra or intracellular reduction of potassium excretion, and impaired renin aldosterone system, reduced GFR and hypovolemia, and the laboratory error. And this is, we shouldn't overlook, actually, because sometimes we have large numbers, for example 8 or something, and simply it's maybe because of hemolysis, maybe because of an upward sampling. If the patient is just making like this big fist when he's just taking the sample, it may increase, do some sort of hemolysis or thrombocytosis, and accordingly it may increase the level of potassium. So we should be very careful for sampling, and we should repeat the sample if you are still in doubt. Still, we are in the potential benefits and risk when we are prescribing RAS blockade, for example, ACE or ARBs or mineralocorticoid antagonists. It's well known that they are cardioprotective, renoprotective, and antihypertensive. One of the excellent groups of antihypertensives are this medication. However, we should carry, just put in mind the increasing the risk of hyperkalemia by virtue of their mechanism of action. So we have a challenge, actually, when we are prescribing, and we are in challenge between the potential benefits according to many guidelines, like, for example, American College of Cardiology, American Heart Association, KDIGO, proven a good benefit for such medication in terms of their outcome for heart failure. On the other hand, we should carry the potential risk of RAS therapy. So what we should do, either to not to prescribe at all or to minimize the dose. And therefore, you may find 70% of patients with heart failure are optimally treated because of the risk of hyperkalemia of these patients. And as I mentioned again, what you should do if you have suffered such hyperkalemia according to all guidelines, you may either reduce or stop these drugs in a trial to maintain the potassium level or until improved, and to resume again, and so forth. And this is the current medication that I'm not going just to talk extensively about it, because we all know about the management of acute hyperkalemia in terms of calcium, which is the gold standard to avoid the cardiac abnormalities, alkalinization of the urine, glucose insulin, which is one of the very important steps in medications, and loop diuretics. However, I'm just stressing on the all this disadvantage of these medications. The main disadvantage is that, okay, there is advantage of such medication at induce remission or normalization of or normokalemia in short time. However, after almost 30 minutes, it happened a kind of rebound increase of hyperkalemia, because we know almost all potassium concentration are inside intracellular. It accounts almost 98% of the potassium are intracellular. So you just remove this 2% or some of this 2% once just improve a little bit, it will rebound again from inside the cell, kind of flux of potassium. And this is the management of the current treatment of chronic hyperkalemia. If we have, we use the current medications to stop the medicine, for example, RAS or blockade, or to discontinue, assess the renal function for GFR, and counsel for low potassium diet. It's out of my scope today, but we should just very careful about low dietary potassium, because it is very important step in the management of hyperkalemia, and prescribe diuretic therapy or sodium polystyrene sulfate, which is the reason that we have nowadays in Egypt. And after exhausting all this medication, we may shift to the new eras of the potassium binders. I think this is my task for today. And this is the sodium polystyrene sulfate, or SBS, which is indicated for treatment of hyperkalemia, and it's known cation exchange reason for exchange of sodium for hydrogen in the stomach, and then exchange hydrogen for other cations in the large intestine, and it's efficient. And regarding the efficacy, it's efficient. It may just lower the potassium by 0.8 to 1.14 milliequivalent per liter, depending on the dosage. If you just use 60 gram per day, it may achieve improvement by 1 or more than 1 milliequivalent per liter per day. Regarding the safety, it's not safe at all, and the risk of acute bowel necrosis, and be careful for that, hypernatremia, diarrhea, and gastrointestinal intolerance. And this is the main disadvantage of such medication. So when we prescribe some medicine for hyperkalemia, we should bear in mind these concerns. There is a clinical need for hyperkalemia treatment that are effective, that's what in below, effective, safe, and well tolerated. And these are the new era for treatment of chronic hyperkalemia with novel potassium binder. There are two kind of binders available, not available in Egypt nowadays, but approved by FDA, and we see everywhere in the ERA Editor and ASN over there, but still not available. But fortunately, someone from one of the commercial companies was thinking about just to prescribe, and how about the market share for such medication. After finishing, we may sit together and to see if it is going to be used in Egypt or not. Both batiromere, and this is the new binders, and the zirconium, sodium zirconium cyclosilicate, have a role in managing chronic hyperkalemia and sustained normokalemia up to 1 years. Optimization of RAS, which is very important. I can use RAS blockade, and I'm not afraid. Okay, so I can use RAS blockade in many instances like heart failure, hypertension, and one of the major crises that we can face in our practice, like cycloderma renal crisis. And the main treatment is ACE inhibitors, regardless the level of potassium, regardless the level of creatinine. This is the main treatment. So we can use it if such conditions, and we can manage hyperkalemia. Generally well tolerated. This is general, knowledge about these groups of medications, and its odorless, tasteless powders for suspension. This is the first one, batiromere structure. It's FDA approved for treatment of hyperkalemia. It's a non-absorbable cation exchange polymers that bind potassium in exchange for calcium, predominantly in the distal colon, and increase the fecal potassium excretion, which is the main mechanism basically of such medication. It's very simple: exchange for calcium. Exchange of potassium for calcium. And there are some studies talking about the bacteromere and its role in hyperkalemia of chronic kidney disease receiving RAS blockade, and it shows that in just serially that there is a gradual sustained drop of potassium after using such medication. The major adverse effect of such medication is mild to moderate constipation in 11% of patients, and it may be associated with hypokalemia. Okay? This is another study talking about the same theme of lowering potassium in patients of chronic kidney disease receiving heart failure, receiving spironolactone. Okay, this is paired heart failure study. Another study, which is MSS, diabetic nephropathy or diabetic kidney disease patient, and using of bacteromere and their long-term efficacy and safety after bacteromere. This is maybe almost 52 weeks efficacy and safety of this medication. In actual fact, there are no definite side effect in this study, just mild constipation, as I mentioned with the previous one. And this is a meta-analysis of bacteromere in different studies that have been done, and it's in actual fact all of them were in favor of bacteromere when compared to the placebo. All of them less than one. So it's considered very good and excellent medication in terms of efficacy, as I mentioned. And these are the major side effects that we may face with bacteromere, including gastrointestinal, basically including diarrhea, constipation, nausea, vomiting, electrolyte abnormality, including hypokalemia, and of major concern, hypomagnesemia. So we should care about hypomagnesemia in such patients. And we may have miscellaneous side effects like edema and urinary tract infection, but not very reported in many studies. This is another study, which is AMBER study, bacteromere versus placebo, to enable spironolactone in patient with chronic kidney disease and resistant hypertension with systolic blood pressure 160 millimeter per mercury, with GFR is between 25 to 24, and serum potassium was 5.1. Patient was randomized to receive spironolactone and bacteromere, and spironolactone and placebo, and the result was very encouraging, and it showed that the time to serum potassium was less in patient receiving bacteromere, and time to discontinue spironolactone was in favor of also bacteromere. I mean, to discontinue spironolactone because of hyperkalemia. Placebo didn't give that effect. And this is the other one, which is sodium zirconium cyclosilicate structure. It is in organic cation exchanger with crystalline structure that entraps potassium along the entire length of gastrointestinal tract. And there are many trials, and this is one of them. This is those clinical trial effect of sodium zirconium cyclosilicate on potassium lowering for 28 days among outpatients with hyperkalemia, which is a harmonized randomized trial. The results were very efficient actually, and I was showing that the time after 48 hours, it reaches the nadir, or the less, even less than normal potassium level. And this is another bold harmonized trial, برضو talking the same theme of lowering the potassium with zirconium. And this is a meta-analysis, also the result of all data regarding the dose-related amount of of zirconium. Mr. Chairman, can you allow me just maybe 3 minutes? Okay, I will finish. خمسة? Okay, thank you. You're generous as usual, Dr. Salah. and the panel are very generous. And this is bold analysis also for meta-analysis for zirconium regarding their efficacy when just we increase the dose. I mean, dose-related zirconium is associated also with better outcome in terms of normokalemia. And this is a long-term efficacy of all of zirconium. It's just associated with mild peripheral edema and mild hypokalemia in all studies that I've mentioned. And again, when we talk about the intolerant side effect, it's mainly range from gastrointestinal electrolyte in terms of hypokalemia and some miscellaneous like edema of the lower limb in 20% of the patient involved in these studies. Just I'm going to talk very briefly about hemodialysis and hyperkalemia and hemodialysis. Just this is the, as I mentioned earlier, the main core of the potassium is inside the cell. It's account for almost 98 or 97%, and only 2% which are intravascular or extracellular, I mean, when just being trapped against the low sodium, low potassium dialysate and return back to the patient. And this is the hemodynamics during dialysis. There is gradual drop of potassium during the 4 sessions of dialysis, and immediately after finishing dialysis, it rebounds again and it may reach the previous level. So we still need some medication to help this mode of dialysis. And there are many studies, actually, all of them, for example, Bachelomere, and one treatment with 12.6 gram daily of Bachelomere was associated with marvelous drop of potassium. But again, as I mentioned, after stopping the treatment, it may recur again and may rebound again. And this is another study talking the CMC during dialysis. And this is a comparison of spironolactone, Bachelomere, and zirconium in different studies that I've mentioned. And dosing of Bachelomere is the recommended starting dose is 8.4 gram orally once daily, and dose adjusted by 8.4 as needed at 1 week interval to obtain desired serum potassium target level and dosage form and strength بتبقى تقريبا 8.4 16.8 25.2 gram per packet or per sachet. And the other one, which is zirconium, the recommended starting dose is 10 gram 3 times daily for 48 hours, and the maintenance once daily and adjusted at 1 week interval, and the dose form strength is 5 and 10 gram packets. And this is emerging data for use of this new medications with acute hyperkalemia. Does it help? Yes, according to these 2 studies, and both of them have shown clearly that if we use this Bachelomere or zirconium with glucose insulin versus glucose insulin alone, it improves the sodium potassium level at 2 hours. However, at 6 or 4 hours, there is no difference. So it helps early only in the acute stage. And there is still remaining gap to address, which one is the role of novel potassium binder in hospitalized patient, use of novel binder in outpatient setting. And this is the prioritized study, which is running study and is going to finish in October 20. And there is another diamond study for the outcome in terms of hospitalization of deaths regarding use of such medication in heart failure receiving other RAS or mineralocorticoid antagonist, and it's going to finish to 2022. And still the cost is a barrier. So if you just know, Bachelomere is almost $850 and zirconium is almost $650. And this is one of the recent, just I've got it from my friend Dr. Saeed, dapagliflozin reduces the risk of hyperkalemia in patients with heart failure. As you all know, DAPA is considered one of the mainstay treatment for heart failure, so still associated with hyperkalemia. And this DAPA, one of the benefits besides their cardio, renal, and all
Dear doctor, your time is up.
And this is, I came to my conclusion that hyperkalemia is one of the major determinant of risk and fatality, and the newer medications such as bacteromere or new potassium binder may give a potential benefit for such patients who are suffering hyperkalemia, especially heart failure, hypertensive, chronic kidney disease patient receiving RAS blockade and mineralocorticoid antagonist. And still, we need larger study to evaluate the efficacy and safety of such medication. Thank you so much for your attention.
Thank you, Professor Kamal, for this illustrative talk. Any questions? Hussein.
I'm very happy that I hear you today live. So alhamdulillah, ala salamtak yani. I'm very, very happy. Regarding potassium, one comment. Potassium includes the medical legal aspects. So if we request a potassium level, we should look at it. Hypo and hyperkalemia are bad associated with problems. And for patients on dialysis, even if the patient presents with severe hyperkalemia and we decided to give drugs that work on distribution of potassium, we should admit the patient and do dialysis. We shouldn't play with potassium because potassium may be fatal associated with medical-legal problems. Thank you very much, Professor Kamal. I'm happy that you present your talk.
Dr. Hesham.
Thank you very much, Professor Kamal Ohasha, my dear friend. I just highlight one issue. I believe in that. It's a triangle of potassium during patients on end-stage renal disease. The triangle should be at the maximum balance. If you have the same levels, you should be on the in the middle of that equally. So the dialysis exactly, meaning one arm is the volume or the amount of potassium removed during the session, and it's around 70 to 100 millimole, equivalent to all dialysis procedures. Makes no difference, low flux, high flux, or hemodiafiltration. Number two, on the same side, from the triangle, is what is the acute effect of potassium removal during the dialysis and the effect of polarization potential and subsequently arrhythmogenic effect. And on the top of that, of the triangle, is the volume or the amount of rebound of potassium following the session. So both the triangle, we cannot miss any point of them. I think the balance between both of them will be much more augmented and beneficial if we use for dialysis population one of the potassium binder. So this is a major player to have a pre-dialysis potassium in the range of 5.5 or less to 4.5, and the acute effect of lowering the potassium on the membrane potentials and electricity will be stable, and subsequently on the top of the triangle is to have a minimum rebound. So we have to encourage that. We have to test potassium regularly pre-dialysis, and we should put one of the drug as much as we can to save lives. Thank you very much.
Thank you very much, dear Professor Hesham and Professor Hussein, for your kind comments. And regarding what you've mentioned, Professor Hesham, it's very crucial actually just to monitor potassium, because not only for hyperkalemia and for hypokalemia.
Professor Magdy.
Thank you very much, Professor Kamal. I enjoyed being with you today. Now, after what we have heard of you and Professor Hussein and Professor Hala, what should the patient eat? This is a very difficult question. You have to give him low salt diet, low potassium diet, low phosphorus diet. Let me finish the dilemma. If you are going to prevent, like what Professor Hesham mentioned, you're going to give phosphate binder, you're going to give potassium binder, and you have to enrich food to avoid malnutrition. So how you look at this together?
I can. It's your wisdom, Dr. Magdy, as we know always that you are very wise, and you will just judge if the patient I'm giving this such kind of potassium binder. So I shouldn't go strict low potassium diet. If I'm going to give phosphate binders in such way, I shouldn't go for such strict low phosphate diet. And if I went for DASH diet, it's going to be enough, I think, if we go for DASH diet, because all data for regarding DASH diet are, I think if I'm choosing between all of these, I'm going to choose for DASH diet because of its potential benefits in terms of controlling hypertension, low sodium, and a lot of benefits actually regarding the related to the DASH diet. So myself, if I'm going to just dialyze the patient and give him potassium binders, so why should I just ask him to be very strict and suggest if I go for 5.5 milliequivalent per liter pre-dialysis, what's wrong? It's okay, because I'm going to remove it immediately on dialysis, and the potassium will go back again to 4.5, and within the 1 or 2 days it will rebound again. So there is no point actually just to put the patient on this very strict kind of diet.
Professor
And
Saeed.
the panel, Dr. Omay, Dr. Iman, what do you think?
Thank you, Professor Kamal. Just 2 points I wanted to add regarding Dr. Hesham. I think if we are over-enthusiastic in treatment of hyperkalemia by conservative measures like beta-2 agonist and glucose insulin and so, usually till the nurse preparing the machine and so, at that moment, actually, if we are over-enthusiastic in treatment, this makes the patient very vulnerable to have rebound after dialysis, because we push the potassium inside the cell, and after a while, it will come out again. That's number one. Number two, we should also not be over-enthusiastic in giving the patient very low dialysate potassium or low dialysate potassium, because it is documented that it's one of the causes of sudden cardiac death of the dialysis patient. Yes. So we should be very wise when we prescribe low dialysate potassium. Thank you so much.
You're welcome.
Professor
Thank you,
Soheir.
Professor Saeed.
تفضل.
Rahia.
I speak in Arabic and in English.
Sure.
Our professor told us long time ago, if the patient wants vegetables, he could peel them like potatoes, peel them deeply to remove the potassium from the potato, for example, and to put the vegetables in soaked water so you can decrease the amount of the potassium in it. Yes. And in our country, we can also remove the pollutants if we put the vegetables in sufficient water before we eat them.
Okay, thank you. Thank you. Thank you.
Any more questions? Okay, I have to thank Professor Kamal Ohasha for this very interesting topic, and thank you all for your attendance. And